you for being patient, but Professor Rajesh Sinha, who is the chief instructor, he's already he has a talk in some other session. So what we are going to do is so this is a course which is dedicated to decision making in patients of keratoconus, and I think it's we are going to have highly specialized talks dealing with the situations where we can practically, bring it into our practice. And we'll start off by Colonel Professor Vijay Sharma, and who's the chief of ophthalmology at the AFMC, and his talk is: Should all cases of keratoconus be cross-linked? Colonel Vijay, please. Thank you.
Thank you. Thank you, sir. So, can we have our slides, please? Yes. So, Professor Rajesh Sinha sir is also here. So, the most pertinent question is, should all keratoconic corneas be cross-linked? So, I'll be elaborating on that. So, first about collagen cross-linking. As we know, it was Wollensak et al. In 2003, working at the Technical University of Dresden in Germany, when they first time came out with the, they published a study of collagen cross-linking in 23 patients who had the keratoconus progression stabilized after this, after doing the collagen cross-linking. So that was the first time, and that is how it came to be known as a Dresden protocol, because it was founded at University of Dresden. So what is the principle is the cornea is saturated with riboflavin dye, and after the saturation of the cornea, a UVA light is it is irradiated with ultraviolet A light at 370 nanometer, which lead to increase in cross links between the adjacent collagen fibers, and that lead to strengthening of the corneal tissue, and also it stops the further progression of the corneal ectasia. So that is the principle. Now if we see, there are multiple indications of collagen cross-linking which have been published in the literature. Primarily, it is the keratoconus, for which only treatment which can stabilize the progression of keratoconus is collagen cross-linking. Other conditions such as pellucid marginal degeneration, post-LASIK ectasia, infectious keratitis, bullous keratopathy, chemical injuries, and TMD, in all these conditions, the collagen cross-linking has been tried and found to be efficacious. So it is being done. Now in keratoconus, now how do we go ahead and what do we do? In adults, it's very important to document the progression of keratoconus, and then you can plan for doing the collagen cross-linking. In children, you may not document, because in children, the keratoconus progress is quite fast. So in children, the documentation is not required. You can straight away go ahead with the collagen cross-linking. For isosmolar collagen cross-linking, the corneal thickness should be more than 400 micron. For hypoosmolar, between 330 to 400 micron, the hypoosmolar collagen cross-linking should be done. Now it has been done, the CXL has been combined with various other procedures in which the vision can be improved. It has been combined with them. For example, topo-guided removal of epithelium in keratoconus, or TREK, in which the PRK and CXL have been combined. In creatine protocol, PTK and CXL have been combined. So it stabilizes the keratoconus as well as it improves the visual acuity by combining these procedures. Similarly, in intracorneal ring segments also you can combine the collagen cross-linking. And there is photo-refractive intrastromal cross-linking, that is a customized cross-linking. So there also the collagen cross-linking can be combined. Now, in addition to corneal thickness, age is very, very important factor to decide how to go about collagen cross-linking. As I told, in adults, you need to document the progression. In children, you need not document the progression. And if there is an earlier onset of keratoconus, there are higher risk of collagen cross-linking failure in children. And in very young children, you may have to consider a general anesthesia, because they may not be very cooperative during the procedure. And a more frequent follow-up is required in the children. Now, what are the criteria which decide that the keratoconus is progressive or not? Now, there are multiple criteria which have been given at the various times. For example, in the Dresden protocol in 2003, It was what criteria they considered was increase in Kmax by more than 1 diopter, patient self-reported deterioration of visual acuity, and need for new contact lens fitting more frequently than in once in 2 years. So this is what criteria they follow. But presently it's a Gomes et al. Criteria. Now in Gomes et al. Criteria, they basically said that there should be consistent change in at least two of the parameters. Now which are those two parameters? That is progressive steepening of anterior corneal surface, progressive steepening of posterior corneal surface, and progressive thinning from the center to the periphery. Now, out of these three, at least two criteria should be met to call the keratoconus progressive. Why they did not give any values? Because values are specific for the type of instrument that you are using, whether you are using an OPSCAN or a pentacam or which type of Scheimpflug device. So based on that, the criteria will differ. So the values were not given. In addition to this, CXL can be done if there is a perceived risk of progression if it has not been documented. I'll come to some cases, case scenarios in the end. So protocols, now we have conventional protocols as well as accelerated protocol. So conventional epi-off collagen cross-linking is the Dresden protocol, and I'll just cover some of them because they'll be covered in detail in the subsequent talks. Epi-on is not considered to be very efficacious. It has poor efficacy, although it avoids the post-operative pain and other complications of epi-off CXL like infectious keratitis or persistent epithelial defect, but the efficacy is not as good as a epi-off collagen cross-linking as is done in the Dresden protocol. Now, of all the, whether it's a conventional or accelerated collagen cross-linking, now, the efficacy of Dresden protocol is still considered to be the gold standard. All other cases, be it accelerated or be it iontophoresis or they are not as good as the Dresden protocol, but they give the advantage of a faster procedure, patient comfort in the accelerated protocol compared to Dresden protocol, which is much longer, and maybe the patient may have discomfort for a long duration lying down for about 1 hour. So out of accelerated also, it has been found that if we use a 9 milliwatt per centimeter square for 10 minutes, that is the most commonly used accelerated protocol at present, and efficacy is almost as good as Dresden protocol. Now, as we know that once we do the accelerated collagen cross-linking, the oxygen consumption in the collagen fibrils happen very fast. So oxygen is required for increased number of cross-links. So various techniques, whether if you have to do oxygen supplementation, does it have a role? Oxygen is required because if oxygen is not available, the collagen cross-linking will not be as efficacious. So we need to supplement the oxygen in collagen cross-linking. This will be discussed in the subsequent talk in detail. Similarly, whether a continuous or a pulsed collagen cross-linking, what is the role at present? So again, the principle is same. For oxygen availability, the pulse one gives a better availability of oxygen and a better cross-linking over a period of time. Iontophoresis, we do not have much of experience. I think hardly, I have not seen many people doing it. Although low intensity electric field is created, current is passed, it enhances the riboflavin penetration, non-invasive epithelium not required to be removed, better saturation than epi-on approach, but again inferior to Dresden protocol. Now there are some conditions in which the collagen cross-linking should be avoided, which include a prior herpetic infection, any concurrent ocular infection, if there is a neurotrophic keratitis, if there is a poor epithelial wound healing, severe dry eyes, autoimmune disorders, and pregnancy. So these are contraindications to do the collagen cross-linking. There are some cases in which the collagen cross-linking failure rates are higher. So there are chances of repeat CXL in such cases, especially in children who have severe allergies and who have frequent eye rubbing if Kmax is more than 58 diopters, and paracentral cones. So these cases have been found to have CXL failure. So you may have to go for a repeat CXL in these patients. Now just a few examples. Now this is one patient. In one eye there was a corneal eye drops, And this was the OPSCAN finding in this patient. So what should we do? So there is a, if you see the steep case 48, thinness package 399. So do we wait for documenting the progression? No. One eye already has an adverse event, other eye has significant keratoconus. So straight away one should go for collagen cross-linking in the other eye in which there is no eye drops at present. This is a pentacam of a patient with the 67 Kmax 67 and a thinness pachy of 355. Again, we should not wait for documenting the progression in this patient because the corneal thickness is already, it's at the lowest level, lowest point when we can do a collagen cross-linking. So again, we should straight away go ahead and do the collagen cross-linking in this patient. So this is another patient. If you see the pentacam values, so thinness pachy is 515 and 506, and Kmax is 49, 49.9. So in this patient, you can wait for progression, documenting the progression. And if you find that there is a progression, 3 monthly or 6 monthly pentacam can be done. If there is a progression, then you go ahead with the collagen cross-linking. This is another patient. Again, this is a serous Scheimpflug image with thinness pachy in the right eye 428 and 376 and Kmax of 71 and 76. Again, in this patient, in the left eye, you have to go for collagen cross-linking rather than waiting for any progression in this case. And subsequently, you can repeat the procedure in the right eye. So thank you very much.
Thank you so much. Hello. Mike. Hello. Well, I think so many of these issues are we are confused about, and Colonel Vijay has really addressed them very well. Is there any question for him? Anybody? Yes. Yes, please.
So it's the same as in others, say you are doing a cataract surgery, so you can stabilize the eye. That is not a problem in GA. So all patients that we go, do otherwise the GA cases for the patients, so there is no issue in stabilizing the eye as such because eye will not be mobile. Only thing is instead of doing an intubation, you may use the eye gel or the other techniques so that child is more comfortable and subsequent complications are less, GA related complications are less. So otherwise there is usually no issue that we get.
We just have to ask the anesthetist that it shouldn't be too deep. If it's too deep, the eye will roll down. If it's if the anesthesia is a little less shallow, then it will go up.
Yeah.
So it's better to ask the anesthetist to give relaxant in such cases so that the eye remains still in the center. And as far as focusing is concerned, just a sharp margin of the focus will tell you that it is appropriately focused.
Yes. Normally, I follow my patients every 3 months. No, after the CXL? Okay, then 3 monthly. Ideally, 3 to 6 monthly you can do. If the patient can report to you 3 monthly, it's better. Otherwise, 6 monthly at least you have to follow up. So, over a period of 6 months. Yes. Post CXL, usually at 1 month we are repeating. Usually 1 day and 1 week we are not repeating. That is how we are following up. We give a BCL. So after on 1 day we just see for any issues as such immediate after surgery. And on the 4th or 5th day we remove the BCL. We stain. If there is no epithelial defect, we start with the steroids. And then at 1 month we repeat the pentacam, any Scheimpflug device. Yes. So if it is associated with say allergy conditions, frequent eye rubbing, so you should go ahead with the CXL in children because it's likely to, earlier onset they are likely to go into very, very severe keratoconus if you do not intervene at a right time. See, it's earliest that I have seen is around 4.5 years, 5 years, Down's patient. So that is what I have done earlier. So if anyone has any other.
Yeah, I've done beyond 6 years only, and If there is allergic conjunctivitis, we should try to resolve that first so that the effect of CXL is reduced if there is significant allergic conjunctivitis. The second thing is that the risk of haze is also high if there is a significant allergic conjunctivitis. So we should try to resolve that, and then we should go ahead and we have done it beyond 6 years of age. And because we have reported a whole series of cases of keratoconus prepubertal as well, and that can be seen even without allergic conjunctivitis. So that has also been reported from our center. So that's why it's better to, because it will further progress at the time of puberty. So it's better to handle it then and there only, halt the progression so that it doesn't aggravate. Allergic cases, the response will not be that good, and there is risk of haze also. So it's better. No, we have to keep managing the allergic conjunctivitis. That is important, at least till the time of 14, 15 years, wherein the symptom of allergy is very high.
Yes. Yes. So, I think we are preferring comfort more than the standard efficacy. So we are going in all patients with the accelerated protocol only. That is 9 milliwatt per centimeter square for 10 minutes. But yes, if Dresden can be done, the GA duration will be much longer in that case. So you have to weigh both the things, whether how long the child can tolerate, how old is the child, and also the benefits of accelerated and conventional both. Yes. 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 No. Once you do the hyposmolar for say around 20-25 minutes, keep on instilling the drops, and then you measure the PACI. If PACI has come beyond 400, then you go ahead, you start the procedure.
You know, thin corneas is the
See, the
topic
thing
of the
is,
next talk.
the thing is that in cases of keratoconus, what happens that the corneal epithelial thickness also reduces.
Yes.
And it is not 55 or 60 microns or that you see in a normal cornea. So you can have a 30 microns, 35 microns, 40 microns epithelial thickness. So somebody having say 367 or something, if you debride the epithelium, it will come down to 327, 330. And anything beyond 330, if you do a hypoosmolar, it will swell up to 400. So that is the cutoff, wherein minus epi, if it's up to 320, 330, then you can go ahead and do an hypo. Yeah, if that is the case, yes, it's better to abandon rather than to cause damage to the endothelium. And I will be discussing about the thin corneas only. So let's discuss in that, yes.
See, if patient can afford it and if you have the machine, you can do the pentacam. There is no contraindication to do the pentacam as such. Otherwise, 3 to 6 monthly, yes. Again, that depends how much, what are the parameters, they are borderline, or there is a good amount of the K max and the other values are good. Then you can follow up 6 monthly, that you can decide patient to patient basis.
And maybe in addition to pentacam, one should be doing a serial biometry also, because as these are children, they are growing. So we have to know whether the myopia is increase in axial myopia. It's because of change of curvature of this thing. So it's very important to do. Otherwise,
Absolutely.
sometimes we get confused. We falsely attribute increase in myopia to progressive keratoconus, which may not be so.
Yes.
Yeah, I think that's